Thank you. Thanks, Sue. Thank you for joining. My name is John Miller. I'm a gastroenterologist and interventional endoscopist. I perform general GI, general gastroenterology, and hepatology, but I spend most of my time performing advanced endoscopic procedures involving the use of the endoscopic ultrasound tool to examine the pancreas. I'm joined tonight by my good friend Anna Paskausky. I'll let her introduce herself as well.
Good evening, everyone. My name is Anna Paskausky. I am a nurse practitioner. I'm also trained as a PhD researcher, and I'm delighted to work with Dr. Miller. I have the pleasure of working primarily with him in the clinic environment while he is doing the advanced endoscopic interventions and inquiries that we are going to talk about tonight. But I have a long background in primary care as a generalist before moving into gastroenterology. So it's really valuable for me to help folks with the whole experience and sort of trying to put it all together, as we know this is can be really challenging for folks.
And that's really our goal tonight is to have an informal kind of conversation to guide you through some of the background that we feel like is relevant with the pancreas as an organ, the cysts that can grow on it, and the potential for pancreas cancer and how we approach in diagnosing that.
And I'll interrupt you there, Dr.
Please.
Miller, just to say I'm going to be interrupting Dr. Miller. We often like to go to the nth. We will go to the nth degree of detail and specificity at times, and then we'll bring it right down to really layman's terms. So we often talk like this together in clinic while we're talking about things. So we'll probably have that same approach tonight.
Yes, even in the rooms, literally. She'll translate. So why are we here this evening? For those who joined later and search for this on YouTube or Google, why did you find this? Well, it's because pancreas cancer and the pancreas is a scary entity in common lay culture and in medicine. Pancreas cancer carries very high mortality rates and remains difficult to treat and very difficult for modern medicine and surgery to really move the needle and make progress in bringing patients to cure, meaningful resection, and sustained remission. Anything involved with this organ scares everyone. I saw a patient today who said that she was told by a surgeon, don't even look at the pancreas if you're doing surgery. Don't even look at it. It can get angry by just a slight tickle of inflammation. And we certainly keep that approach in medicine as physicians as well. From a patient perspective, patients commonly understand or feel or identify when anything is wrong with this organ that they have a grave illness, whether it's pancreatitis, pancreas cyst, or a solid area of the pancreas that's concerning. For families, anything when their loved one has a pancreas finding, you'll often hear someone say, well, so-and-so has a spot on their pancreas and their palms will be white and sweaty and anxious. And we appreciate and understand the anxiety that comes along in assessing this disease and how much anxiety it carries for the family, even if it is, in our opinion, and as I hopefully can show you, a very non-threatening entity. And it's stressful for the healthcare team. We worry about how to find this disease when it exists in the pancreas. It's a very difficult structure to examine and to study despite modern imaging. It's challenging to forecast the severity of this illness, particularly when it's an inflammatory disease. It's difficult to stage when disease arises from the pancreas, including pancreas cancer. It's challenging to communicate what we know and frankly what we don't know to patients and their families transparently. And it's, as an interventional endoscopist, it's an important structure that we're always very cautious with in trying to avoid doing harm to, because it can be injured during our procedures to intervene on other structures. So our outline here of how we plan to proceed, we'll just give you a brief overview of what this gland is, what it does, where it is. We'll talk about pancreas cysts first and take you through a journey of a patient, a typical patient or a stick figure patient here. And we'll talk about the risks of pancreas cysts and what they can progress to and what they can't progress to, and hopefully offer some reassurance as people are maybe searching for this video down the road to help them understand a recent finding on an imaging study. And then we'll get into a little bit about pancreas cancer, talking about who's at an increased risk, how it is diagnosed, and what happens following a diagnosis. We're not surgeons, we're medical oncology doctors, but we work very, very closely with those specialists as part of their collective team. And so we're able to help patients navigate those early steps following a diagnosis and staging, and even subsequently helping to take care of them. So the pancreas, what is it? Why is so much noise about it? What is so complicated about this organ? It's a 6-inch fleshy organ in the center of the body. How can it be that complicated? This picture from the NCCN can maybe highlight for us why it's difficult is because it sits in front of the kidneys, pretty important structures. It sits below the liver, and it sits behind the stomach. And it sits and ensnares itself around critical blood vessels within centimeters from the aorta, the major blood vessel providing blood flow to the belly. So it's a difficult structure to see. It's a difficult structure to intervene on, and it's quite challenging for us to even image it with MRI scans and CT scans. What does it do?
So,
yeah,
Dr.
please.
Miller, would you say this is sort of a New York City or Boston sort of like everything is happening? There's a lot of crossroads. There's a lot going on there.
A lot of traffic on the scale of Grand Central Station. I mean, you've got critical pipes and critical trains and nerves all running in relationship to this. And if you look at it, it kind of looks like a question mark turned to the side on a pivot. And in that question mark is the gland literally making a hook around a structure that gives a lot of blood flow to the liver called the portal vein and the artery that gives blood supply to the liver. And that's part of the challenge when we take care of these diseases is how closely it comes around the blood vessels that exist there. And we'll talk a little bit about that when it comes to staging, how it's really its location and what disease there gets into that dictates what the surgeons can offer in the timing of how they'll offer that. And so, yes, it certainly is a hub, and it's a very active hub. It regulates blood sugar, and it helps to help you either rest and digest and store your sugars and carbohydrates, or to release glucose if your blood sugar is low. And that's really the realm. This organ is so important and so complicated in some ways that it takes 2 or 3 specialists to take care of. So there's an endocrinology doctor who are doctors who specialize in diabetes and diseases of hormones. And they take care of the endocrine pancreas or manage those diseases, as well as primary care and internal medicine, family medicine physicians and providers. And then there's the gastroenterologists and the surgeons who are often involved in taking care of the exocrine pancreas, which is just a fancy word to say it's the enzyme making food breakdown chemicals that this organ makes and pushes into the GI tract that helps you digest your cheese and your meat and your hamburger, as well as your carbohydrates and pastas. So it's very important for absorbing food and helping food to be broken down. And when there's diseases in this organ, we can see people lose weight frequently because those functions are not happening well. We can see difficulties in blood sugar control because it's not doing the job it is supposed to do. So I think we got into this a little bit, but why is it so hard to examine or just take the thing out if it's got a disease in it? And again, that has to do with its location, what it's next to, and how difficult it is to access, and how many structures have to be moved and mobilized and safely reconnected when interventions are undertaken. So let's get into pancreas cysts a little bit. This is a drawing I made, and what I was trying to capture here is a cyst is a pretty simple. It's a pretty simple structure. It's just fluid-filled space lined with cells. Cells that normally, or in many kinds of cysts, exist in a tube. In this case, exists in a ball. And the fluid in this.
So, Dr. Miller, I want to cyst can be a scary word for people, but these are things that people have experience with, right? Like a blister or acne or things like that, right?
Those are really cysts as well, or kind of, and some of those are what we call pseudocysts. They're a cavity, a space with fluid in it, and fluid that often is not supposed to be there or in normal circumstances isn't there. And what lines that cyst is in some ways what we call a fake cyst or a scar cyst in the pancreas when it's lined with just scar and dead tissue, or it's cells that are alive and that normally live in a little linear tube. But in this case, something was funny. They're growing too much fluid, and now they're growing a big ball like a water balloon. And the balloon rubber is the cells, and the water is the fluid in the cyst. Does that seem make a little more sense?
Oh yeah, totally. Okay. I think it's just great to know that cyst doesn't mean necessarily something terrible is happening.
No, and there's many cysts that we find in the pancreas really are not concerning at all. Some of them aren't even cysts; they're just areas of scar, and fluid happens to be collected within it. So here's a cyst we have here, a typical cyst of the pancreas. It's cells that are alive and fluid in the middle. not that threatening right now. And many of these are really not that threatening. And here's a pancreas, a patient with pancreas. And here's a patient with pancreas who's going into a tube. And this tube is an MRI scanner or a CT scanner. And many times it's a CT scan. In fact, most of the times in the practice that we have, it's a patient who's undergoing an MRI scan or a CT scan for something that really wasn't related at all with the pancreas. And in many of these patients, they're kind of, as my senior partner will call it, victims of modern imaging, where now there wasn't a disease state before. The patient was pretty content and okay. Now they're pretty scared because there's something wrong with the pancreas. They've got a cyst or a spot on the pancreas, and that creates a lot of anxiety for patients, for families. And as we talked about, the rightfully earned baggage this organ carries in contemporary lay culture will generate a lot of stress for everyone involved here. And what we're trying to say, and we'll say this a couple times now, we'll say it at the end, but in a vast majority of these cases, when we find the cyst doesn't have any relationship to the symptom or to the reason for the scan that it was done in the first place, and may not really hold any value of clinical importance to the patient. But as you can see from this brief stick figure, it's still causing them some trouble. So let's talk about this in a little bit in terms of numbers, and this is taken from our society, the American College of Gastroenterology guidelines. Like many things, I like to say this in clinic, when you see many guidelines about the same thing, there doesn't connotate the most confidence in modern medicine. When every society has their own guidelines about how to approach the management of a pancreas cyst, it makes you wonder if anyone's really got it all figured out. But what we'll present here are commonalities amongst the guidelines between the different societies from the East and the West, and I think it'll give us a good summary of what's a good common clinical practice. So in general, the presence of pancreas cysts in people who are asymptomatic for any pancreatic disease can be between roughly 3% and almost 14%. And we see these very, very commonly as people get older. And I'll commonly tell patients this quote: when you're getting an MRI scan to look at the kidneys, to look at adrenal glands, to look at many other structures in the abdomen, sometimes even the spine, you may find cysts in the pancreas. And in patients over 70, 40% of the time that there's imaging done for any reason outside of the pancreas, there are going to be cysts there in the pancreas. That's a lot of patients. And in the vast majority of them, this will have no bearing on a clinical course for them or really relevance on their health. But this is what scares everyone. And it scares and myself in the clinic on a regular basis as we try to identify and stratify risk, is that some pancreas cysts have the potential for malignant transformation or to convert to cancer. I'll say this here. I should have put it in a slide more deliberately, but most pancreas cancer does not come from pancreas cysts. Dissimilar to a disease that we're very familiar with in GI, polyps of the colon, which can progress to colon cancer, most pancreas cancer doesn't come from the cysts in the pancreas. In fact, there's some data actually out of the East that in patients in whom have pancreas cysts that are followed on MRI imaging, God forbid when a tumor does develop, it doesn't even develop in the area where the cyst was. The cyst may have just been a marker for some instability in the gland. So this is what, go ahead.
Oh, John, sorry, Dr. Miller. When you say the East, do you mean Boston or do you mean Japan?
Oh, I'm sorry, Japan.
Like which? Yeah, okay. Because our neighbors to Boston, we salute them, and they're doing great work out there.
And absolutely, they're a great help to us. But this good publishing was done by our friends in Japan. Yep. So the reality is it's exceptionally rare for a cyst to transition for cancer. And this is like a take-home point. The probability that a cyst has cancer within it at the time of imaging. So the time when you get that report and your heart is pounding and you're calling your loved one to say they found a spot on my pancreas, it's some kind of cyst in the pancreas. The vast majority of the time in this case, there's no cancer within it. And it's exceptionally unlikely for incidental cysts to convert over a short period of time to cancer. So for all incidentally discovered cysts, the overall conversion rate for a cyst to an invasive cancer is less than 0.25% per year. And again, at the time of imaging, when a cyst is found, there is cancer in roughly 0.25% of the time. So less than 1% of the time when someone finds the cyst incidentally on an imaging study, there's something concerning growing within it.
And Dr. Miller, here I'm just going to back you up and just
Please.
remind folks who are afraid of statistics. If you
Yes.
flip a coin, that's a 50-50 chance, 50% chance that you could get a tails or a head. So we're talking about 0.25%, less than 1%. So that I think is important for those who get nervous with the numbers.
Yeah, that period. You're right. That's exactly. Definitely valid pause there. What's challenging when you're trying to learn these cysts as a student and as a clinician is that we have various kinds of cysts, but we rarely ever use these terms to make a definitive diagnosis of what kind of cysts they are. We're oftentimes judging by their risk factors and what's concerning about them, and rarely using the terms to describe what they actually are as a cyst. But there's a lot of different kinds of cysts in the pancreas. There are cysts that are called pseudocysts, and these are cysts that are often seen when there's an episode of pancreatitis. For example, if someone had what they call gallstone pancreatitis, they may find that on a follow-up imaging study done for another reason, like kidney stones, they find a cyst in the pancreas. And then there's, as we said here, it generates a lot of anxiety. And then they look back and say, well, they had a CT scan when they were in the hospital for the pancreatitis, and there wasn't a cyst there. But now on the CT scan done a year later for the kidney stones, there is a cyst there. So what's going on? Is this a new worrisome process? Most likely it's what's called a pseudocyst. And in those kind of cases, we have pretty good evidence and guidelines to say, unless there's a red flag issue, we don't even need to pursue further evaluation, because those cysts are actually just fake cysts. They're areas of scar. When the pancreas gets inflamed, those enzymes that are supposed to get pumped out to help you digest your food, well, those can actually wall off and make a cavity. And in that cavity, fluid comes in, and scar goes on the outside. And so it can look very similar to any other kind of cyst that actually has alive cells there. Another kind of cyst that we don't see too commonly and has a lot of value in making the diagnosis when we're able to is a serous cystadenoma. And this is what kind of this is a cyst that's of connective tissue. It's when there's an overgrowth of some of the supporting tissue, what we call this, the fibrous tissue of the pancreas. And they have very characteristic appearances on imaging studies that sometimes can make a pretty confident diagnosis, or very close to it in terms of what this serous cystadenoma being present. And when it is present, we can walk back and not need to follow that. Usually, if when this question is raised, we'll end up pursuing a sampling of this area and try to get something in the a formal fluid analysis to give us confidence this is what we're dealing with. But when we find these things, we don't need to follow them further because they don't have any cancer risk. These are the cysts that we see most commonly under this first category of cysts under cancer potential is IPMN. And I would have put the full word up there, but it's a really long word, and it doesn't really, it's almost too confusing to explain, but it's intraductal papillary mucinous neoplasm. And these are the cysts, they come in really kind of two flavors. And one is the side branch IPMN. This is a cyst that makes mucus, and that is a normal solution made by the pancreas cells to help you with digestion and mobilization of secretions from the pancreas gland to shuttle it over into the GI tract. And when there's too much of that mucus or snot being made, the cyst can get bigger and bigger and bigger. And Anna and I in the clinic will kind of joke about, we'll call these snot cysts, because we know that snot's gross, these are bad cysts, and it helps us categorize in our mind's eye which cysts we worry about and which cysts we don't need to worry about. So things that have the word mucin in them are cysts we take very seriously, because they have more of a risk for the progression towards cancer in a patient's lifetime. And there's good guidance on how to survey these patients with these cysts. The most common is really the least concerning here, the IPMN side branch. It's just a small little cyst that doesn't hold a connection to the main pipe of the pancreas. A cyst that we see rarely, but an important one, is called the main duct IPMN. And this is a cyst that really is more of a change in the main pipe of the gland, where too much mucus is being made and it's distending the duct of the pancreas, and it has a characteristic look, and we can identify that, and it does have a higher risk of pancreas cancer that we watch for. A less concerning kind of mucus producing cyst is the mucinous cystic neoplasm. And we can catch these with imaging, and we can get a pretty confident diagnosis with them from the endoscopic ultrasound sampling techniques that we'll talk about a little bit later. And then of the kinds of cysts that we can see, there's two other rare entities, but ones that we have seen here at Baystate within the last year, a solid pseudopapillary neoplasm, a kind of a slow-growing, bumbling group of cells overgrowing each other with fluid in the middle, and an overall not a very threatening one can be removed with surgery, and then a cystic pancreatic neuroendocrine tumor. A lot of words there to say basically they're cells that live in the pancreas, they're nerve and endocrine cells, and sometimes they are growing in an out-of-control way, and they'll make a cavity of fluid, and it looks like a cyst, and we usually can get these cysts well before they're a problem for patients. But in general here, I think the ones in orange are the ones that we see, or the ones that we're the most concerned about, the ones we see most commonly. And that will be the ones that have the risk that can progress towards the pancreas cancer we're all familiar with. Who should see me for my cyst? This is a tough question, and we'll ask it for you. And I think it can vary, like most things, on where you are in the country and what resources are available. In general, a lot of these small cysts, when there's not red flag symptoms or concerns, and we'll talk about what those are, can be seen and managed in the primary care clinic, where a radiologist, when these findings are found incidentally on some kind of, I use the example frequently of the kidney stone imaging study that shows small cysts in the pancreas. When they're small and usually less than a centimeter, a radiologist working with your primary care team can give a really good, strong plan of when that should be assessed again with an imaging study. And that can be done without having to bring all the stress and challenge of bringing someone to see a specialist for this. Generally, a lot of these patients are assessed by a gastroenterology group or advanced endoscopy group, which is what we are here at Baystate. And we use special cameras that actually have an ultrasound apparatus at the end of the scope that's able to get refined, high-quality images of the pancreas and even can sample cysts in the pancreas. And then in some areas, a surgeon is a great person to see who can interpret the imaging and follow the guidelines closely and give patients counseling and not necessarily need to involve a gastroenterologist or advanced endoscopist, and could work maybe on an as-needed basis with one of us here in GI to help perform the procedures to sample the cysts if needed. But these are experts who very comfortable in evaluating pancreatic disease and perform surgery to remove these cysts when they're concerning, as well as tumors, God forbid, they develop. Any questions there, Anna?
No, I think that's a great point. I think there's different options based on where you are, and sometimes you'll also see folks like me, so nurse practitioners or PAs in clinics. Sometimes you might see another physician in gastroenterology, as we're trying to figure out how to really determine where your cyst falls in all those ones that Dr. Miller was going through. So you don't have to figure that out. We figure that out for you.
Exactly. This is our side in scheduling and triage. I like this quote a lot with cysts, and I like actually with most things in medicine. I think it's very applicable here. So how do you judge a cyst? You judge it by the company they keep, because you're rarely ever going to be taking a cyst out and then studying it with an expert under a microscope. Yes, we can sample. There's things we can do we'll talk about how we do that. But for the most part, you have to judge these things on morphology and on meaning like how it looks on imaging and what the patient's symptoms are and what their individual risks are. And this is where it gets challenging. And this is where, in the right patient, a clinic encounter and a clinic consultation is a great benefit to all parties involved. Because it's more than just the CT scan in many cases. So based on the different guidelines that we alluded to from the East and the West, there's a commonality of what we call the concerning features of a cyst that help us judge which ones are ones we need to worry about and move along quickly with, and which ones have some time for us to get the patient in the office, have a conversation, and then make some decisions. One of the first things we look for is the size of the pancreas duct. This is the major pipe of the pancreas. And so the pancreas, again, makes secretions, which then need to be passed through a main pipe, the pancreas duct, and then pushed along into the intestine so they can do what they're supposed to do, which is help you digest food and digest and absorb nutrients. So when these cysts, which we've alluded to, these snot cysts, these mucus producing cysts, when they make too much of this junk, it gets into the pancreas duct and it dilates the duct. And that seems like a rough surrogate and kind of a sloppy way to assess such a
hold on, Dr. Miller, I got to stop you there. You said a lot of big words. So when you say dilate, just review, and then a surrogate. Oh, we're getting really exciting.
So
by dilate, you mean it gets bigger in a place where it shouldn't be bigger.
It gets bigger
like when you have a tube that it has too much pressure and it starts to, you got that garden hose that you probably should have replaced and it kind of pops out, right? That's what you're talking about, dilate?
That's even better. It's that garden hose that's nice and flat and small, and then it's pretty plump and dilated. So we see that means that there's something going on here that needs closer attention and assessment. Similarly, in generally the size of the pancreas cyst, when it reaches above 2 centimeters, we start to be more concerned that this is something that needs to be assessed within the next few months, and one that has a higher risk of progression towards precancerous changes or a dangerous progression pathway, one that has to be watched closely. So these are you're right. Even the word surrogate is not a great word to use, because what does that mean? These are signs that something's amiss. It means that cells that are living in the wall of this gland are making too much juice and causing a change that we can detect. And so we use the size to
So Dr. Miller, you are a detective and you are putting all the clues together to figure out what's really going on. It's like a great detective movie, but it's medical detective work.
Yes, we are using different pieces of information here to try to surmise what is the threat of this process, of this cyst. So we'll look at the size of the cyst. We'll look at the size of the duct. We'll look for if there's any solid areas to suggest that the cells that line the cyst, the rubber that is that wall of the rubber water balloon, are growing on top of each other and growing into a ball within the cyst. That's a worrisome sign, and a sign that we wanted to get this cyst sampled and assessed by an appropriate team. In addition to these things which are seen on imaging, and we've listed these here, these are measurements. There are clinical and personal risk factors that are really important that we'd like to have that clinical assessment on some patients to help stratify and make decisions. When we see that the gland has had episodes of inflammation, of pancreatitis, severe pain, nausea, vomiting, requiring someone to go to the hospital for admission, that speaks to us that something's wrong in this gland. Whether it's related to the cyst or not, something is active, and that warrants more of an urgent assessment within the next few months. Family history of pancreatitis or pancreatic cancer, those are things we take very seriously in this area, and we'll talk a little bit about that later, as well as personal risk factors that increase the risk for pancreatic disease and pancreatic cancer. Those would include smoking, some pesticide exposure. Anna, please. Any questions?
Yeah, and on this one, many of you will be, some of you are patients already at Baystate. Some of you are new to our system. Sometimes we review notes from your other doctors and care teams. But I just want you to know, we always double check these things. It doesn't mean that we aren't reading what your other care team has led, because sometimes we discover something that was overlooked. And that's why we are really cautious about, having that extra information. Because as you can see from the slide, talking really gives us important information, just like the imaging does, and sampling that Dr. Miller can do.
Absolutely. That is what tipping point for some of these decisions that we make is a clinical assessment. So making a plan with these cysts and putting this into a little bit more of a formal, recallable format here. So in general, small cysts, without these worrisome findings that we mentioned, this can be done either with us giving some formal or informal guidance to your primary care, or the radiologist giving that guidance to the primary care, and having this with a surveillance study done with an MRI scan, typically with a primary care about 1 to 2 years after the initial finding, depending on the size of the cyst and those features. Or if the cyst is greater than a centimeter and there are risk factors, sometimes we can be assistance in making a plan for how close the intervals of surveillance should be, whether it's MRI scan in a year, or perhaps an MRI scan in a year and then spaced to 2 years and then 3 years. we can help with that. And this is when we start to get more involved as a consultation service in gastroenterology. So how do we decide what to do with these larger cysts and those with high risk features? This is where we get into some of the art of medicine. I think that I might have messed this up, Anna. Hang on one second.
It's all right. It's the PowerPoint, not us.
Okay. So what we want to do when we're seeing the patients in the office to assess, and this is where Anna really helps us a ton, as I'm mostly in the procedural unit, is evaluating the patient and their overall medical conditions and their risk in terms of tolerating an anesthesia-supported procedure. These procedures can be done with the sedation that's done for a colonoscopy. And in general, the risks of them are pretty similar to a colonoscopy, except when we start to sample a pancreas cyst. And also to talk with the patient and the family about why we were doing this study. Is this information going to change management? Is this finding in someone who's relatively older, towards their 80s now, and not someone who'd want to undergo surgery to remove something that has the potential to become cancer? Is it really worth even asking these questions and having them kill an afternoon waiting for an MRI scan and the stress and anxiety and expense that comes along with that? Those are tough decisions, and we try to have those discussions in the clinic. And oftentimes we have patients maybe bring a loved one because it's confusing. And Anna and I and our team, Dr. Duong and Dr. Zakaria, will try to sort through this discussion with them. In general, what underlies a lot of these decisions about if we're going to pursue further evaluation is that when we try to take these cysts out with surgery, which is something that we do not perform as gastroenterologists, but we rely heavily on our colleagues, obviously, from surgery, the risk of dying from surgery to remove a cyst is 2%. And the risk of serious complication can be upwards of 25-30%, something that could involve being in the hospital for an extended period of time, needing other interventions, having to come to the hospital unexpectedly for difficulties to follow. And so these decisions about when to proceed with actual surgery to remove a cyst are very difficult. And our team at Baystate Dr. Osuna does a great job with patients and their families in navigating this. And we try to head that off, though, when we can, and be pragmatic and say, is this something that you'd be willing to consider doing? Or would you be able to really even survive this kind of major abdominal surgery? And if the answer is you're not interested, then maybe we just don't pursue further imaging. And we can help patients and their primary care team comfortably walk away from this path of having to pursue further imaging for these things.
I would say, Dr. Miller, in clinic, I often frame it as what is the risk and the benefit of doing something, and what is the risk and benefit of not doing something. So we really try to get to that point of what is important to you as a patient, with inputs from your family, looking at your whole picture, because it's not, there's not a guideline that says you, XYZ person should proceed in this way. And you always have choice, and we respect that. So it's complicated, which is why it's great when we can sit down face to face together to navigate all those things.
Absolutely. And then we all feel, as we said, the pancreas provokes anxiety in us as clinicians, and having that dialogue and mutual understanding is what makes it possible for us to embark down a pathway of evaluating further when we feel like there's a shared understanding of what we're doing and why we're doing it. Say you've done your Google search, you've looked at this video down the road, and you're getting ready to come meet with someone to talk about your pancreas cyst. What are things that you could do to get ready for that visit? So trying to get a sense of the family history, that great aunt or that aunt that had some kind of cancer in the abdomen, and someone said stomach cancer, but maybe they meant that it was just their stomach, or it was just their abdomen perhaps, and maybe the cancer was actually from somewhere else. Trying to clarify that, with family would really be of help to their consulting team, because this is pancreatic disease, stratifying the risks of progression towards cancer has a lot of relevance with family history of pancreas cancer. So knowing that and getting out even to second degree relatives, half siblings, cousins, aunts, grandparents, be a detective and help us to make an accurate assessment by getting that information. And then pancreatitis in the family is really helpful to know, particularly if we didn't have a good reason for it. There wasn't a gallstones or a history of difficulties with alcohol abuse that led to the pancreatitis. Then why did they have it? What did the docs end up saying? And was it ever even figured out why? That has relevance in us assessing pancreatic disease. If you had prior imaging that information is really helpful. The example we used about that patient with pancreatitis and gallstones who didn't have a cyst, and now they have a cyst. And in fact, this isn't even really a cyst. It's a pseudocyst. It's a scarred area that's of no negligible importance. Having old imaging studies and in modern medicine, or in modern times, people move around all the time. They're, in school somewhere, they're working somewhere, they change jobs. Well, our teams can help track that information down, or if you can own and have a copy of the C, that's even more helpful. But knowing where those reports are and bringing them or alerting the referring office to them is very helpful. So how do you evaluate a cyst? I'll try not to beat this to death, but again, CT scan, great tool, fast, easy, readily accessible, can be done really almost any hospital in the country. And its strength is it's quick and it's easy for all of us to read. It doesn't necessarily have to have a radiologist to interpret all the fine pieces of it, but it does result in ionizing exposure, radiation exposure, which can carry risk over one's lifetime cumulatively for cancers in the pelvis and the abdomen. MRI scan, longer study, more limited availability, not available at every hospital in the country, has great resolution and really helps us see the plumbing system of the pancreas. That is a fantastic tool. It has replaced much more invasive ways to assess the pancreas, including the ERCP procedure for diagnostic purposes. It doesn't have any ionizing radiation. It can be challenging when we're trying to schedule it because it's a longer study. It takes special expertise and limited machine access. In addition, we can come across some barriers with insurance approval. And this is one of the reasons why we often need to have a clinic consultation to help us support and advocate for this study when we feel it's needed.
Also, on that point, Dr. Miller, I also want to point out some people experience claustrophobia around MRIs, and that can be a barrier or feel like a barrier. And those are definitely things we can talk about, strategies to address that, both from our perspective, but also partnering with your other care teams.
Absolutely, that's an overcomable entity. In most cases, we can work out. Endoscopic ultrasound. This is where I spend a lot of my time at Baystate in the procedure unit. This is an endoscope, a camera scope that passes through the mouth while the patient is sleeping, and it goes through the stomach and into the intestine, and it has a camera on it so we can see where we're going, but it also has an ultrasound probe, like the ultrasound probes that are used to examine other parts of the body, including for fetal monitoring. And
when people are pregnant, they're looking at the babies.
That's the one. That's the and we can position this in different parts of the stomach and the intestine and get really good pictures of the pancreas and other organs around there, including the plumbing system below the liver, the biliary system, the liver itself. And we're able to do a lot of different interventions from the stomach now with this tool here at Baystate. But from today's purposes, it gives us great pictures of the pancreas, and it lets us, in some cases, even sample the pancreas. In general, when we're just looking at the gland and examining small cysts and trying to make assessments of the gland, the risks are pretty similar to a upper endoscopy and even lower risk than a colonoscopy. The risks really arise with sedation for the procedure, which can be a little more extended because of the length of time we have to do this exam, and sometimes we need patients a bit more still than for those procedures. When we start to introduce considerable risk and for this procedure, more risk is when we have to embark on sampling the pancreas in one way or another, whether it's sampling a solid area that we'll talk about later, or if it's sampling a cyst area in the pancreas. And
Dr. Miller, sorry to interrupt here. I don't think you've explicated what sampling means.
That's didn't say. That's well said. And you're on. This is us passing a needle very carefully under an ultrasound probe.
A very small needle.
Very, very, very small needle through the wall of the stomach or the intestine into the pancreas, into the area where the cyst is, to take fluid and then send it for analysis. In some cases, when it's more of a concern, we'll talk later for pancreas cancer, it's taking tissue and taking solid pieces of the pancreas. But in this case, it's just sucking the fluid through the needle. It's in the pancreas cyst and sending it for evaluation. And we'll give patients antibiotics for this typically, and we counsel them closely. And fortunately, our rates of these kind of complications are less than this number quoted here nationally and internationally. Any other questions about this that come up in conversations? You talk about this more with patients than I do, I'm afraid, these days.
Yeah, no, I mean, I think you covered it well, which is really, it's the real estate. Again, it's New York City, so everything's close. So we really take advantage of that. So the downside is what we talked about before. And the upside is now we can do this endoscopically with a little camera scope and a tiny little needle, and you don't always need to use the needle,
Very,
which is
very
great.
important point there. And we make decisions when we're in the procedure, and I'll get into this here about what we're going to do. So when we're evaluating the pancreas, we look at the entire gland. We look at it from every position that we can, and we determine if sampling the cyst is going to make a difference in management. If I can deem that there's no major high-risk features here, and it looks pretty simple, and I don't think that this, in discussing the course with the patient, this is someone who really wants to do much beyond make sure nothing is too concerning in there. We may not need to do further sampling of it. But if the size is greater than 2 or 3 centimeters and there's concerning features, we'll likely proceed with taking fluid or aspirating it from the pancreas cyst. And then at the time of the procedure, based on the results that we get, and actually even at the time when we're doing the exam, we're going to make some decisions about if the patient should go see a surgeon for further discussion about removal, or if we should just continue to survey the patient with MRI scans subsequently. So we owe it to the patient and their family as soon as the results become available, and there's some variation in how soon we get those results based on the tests that we're actually sending the patients for. To give them guidance on the next imaging study, when they should get that done, if we should have them go see a surgeon for consultation about removing this part of the pancreas or this cyst, or if we're not too worried here, the findings are reassuring and we want to stop surveillance. It's not worth pursuing further. When we do take fluid from the cyst, we send the cells for analysis that we can get from the fluid. If we can get some, there's very rarely they're actually shedding off meaningful amounts of cells. We send it to look at the sugar content of the cyst. We look for markers called CEA, a marker that helps us stratify if the pancreas is one of these mucus-producing or mucin-producing cysts, those IPMNs we talked about. We look for pancreas enzymes to help us characterize what kind of cyst it is. And then what we're able to do now pretty readily is send the fluid for analysis to look at the DNA, the genes that make up that are in the fluid. And we look for certain changes in the DNA called mutations that are associated with a higher risk or lower risk for progression towards pancreas cancer. And rarely do we actually sample the wall of the cyst. We do, and there are times we can get into in details of his questions later that we will stick a needle to take tissue from the wall of the cyst or use special tools within the needle, but that's a little out of the scope of what we're talking about right here. So there's a lot of information that we can get from this exam, and it's more than someone can really comprehend or understand after they just got sedation and are in the recovery unit. So for most cases, when we're taking fluid from the pancreas, we do want you to come back another time to not get a procedure, but to talk with myself or with Anna or Dr. Zakaria or Dr. Duong in the clinic to interpret these findings and where to go from here. So moving now in the last few minutes towards pancreas cancer, we'll progress and talk about who's at an elevated risk, how do we make the diagnosis, which we've kind of already reviewed with the endoscopic ultrasound, and then what happens after. So we've been through this a bit, and this is a good diagram, again, from the NCCN, the National Center for Cancer Networks, that shows the location of the pancreas over a major blood vessel structure. The red tube in the back is the aorta, the major pipe. And then coming off there is the major branch point called the celiac axis, where blood vessels come off that give blood supply to a lot of the gut. There's a lot of lymph nodes in this area. There's this major vein over here called the portal vein, and there's this structure here called the biliary system. So a lot of really important structures, and this fleshy organ that isn't itself that complicated manages to get around nearly all of these. The pancreas cancer we're talking about is pancreatic ductal adenocarcinoma. The other cancers that can be seen in the pancreas include neuroendocrine tumors, diseases, cancer from elsewhere that spreads and lands in the pancreas. But for the most part, right now, our conversation will focus on the most common one, pancreatic ductal adenocarcinoma. Oops. In general, how in my mind's eye put this together are cancer cells, or a tumor is just a ball of cells that are growing in an uncontrolled way. So cancer is just when the cells are no longer following instructions to die when they're supposed to die, or stop growing or stop reproducing when they're supposed to, and they grow out of control. So when this happens and they grow on top of each other in a disorganized way, they come together and form a tumor. The challenge with this disease is that pancreatic cancer cells grow into nearby adjacent structures. They grow into their neighbors very, very quickly, and they can even break away from where they started and land in other organs. And organs, one of my colleagues in surgery talks about as filter organs. Dr. Fish will say the lungs are a filter organ. They can even spread to the lungs or to the liver, because those organs are where our body kind of sifts through the blood. What causes pancreas cancer is a very difficult question. We really don't know, but we know what increases the risk for developing it. Smoking, long-standing alcohol consumption, obesity, certain pesticide exposures have been associated with pancreas cancer. Nearly 1 in 10 pancreas cancers are hereditary, meaning they carry a strong inherited component. And this is frequently seen in patients who have family members with history of pancreas cancer, as well as breast, ovarian cancers, some colorectal cancers, and even melanoma. And we can see pancreas cancer arise when there's been long-standing disease such as chronic pancreatitis, scarring of the gland, or even diabetes can be an increased risk for pancreas cancer development. Who should be screened for pancreas cancer? This is just kind of a specific slide that we really discern and translate for patients in the clinic. And this is more for a reference for those who are digging this out later on when this goes to YouTube or wherever Baystate distributes. But those with Hughes-Jaeger syndrome, or what's called STK11 mutation, patients who have CDKN2A, often associated with breast cancer. There's been some controversy about the BRCA or the BRCA genes. Previously, the major sources of guidelines about this, and again, we're alluding to this conflicting guidelines scenario, which is challenging for all of us to navigate, but we do so diligently. These patients, under some of the guidelines that are available now, particularly those in GI, do warrant screening independent of having a family history. Whereas traditionally they were grouped with the group below, patients who had mutations and were carriers of mutations called ATM, the Lynch syndrome mutations, the MSH mutations, PLB2, often breast cancer associated mutations. Those patients who had at least one first-degree relative would be candidates for pancreas cancer screening. And then the last group is patients who've had one first-degree relative who also had a first-degree relative with pancreas cancer. That's called familial pancreatic cancer kindred. And those patients meet criteria for screening, even if we don't have an identifiable genes associated with them. I'll leave this in there more for reference later if someone does need to dig this out to help them navigate next steps or what findings they have. Anna and I do this in the clinic frequently, and we enjoy it. We have a clinic discussion to discuss the candidacy for the screening protocol, explain the tests that patients will undergo. We explain and draw out the endoscopic ultrasound. We talk about the MRI scan. And the way that these patients are screened is they typically undergo an MRI scan alternating with endoscopic ultrasound. That's the endoscopic procedure every other year. It's a pretty arduous road. In some patients, it's the right move, and in some patients, frankly, it's not what they want to do with their time, and that's very reasonable. The benefit we find, and why we really take a lot of value and satisfaction is that we feel that, particularly in patients who are cancer survivors, oftentimes our breast cancer population of patients who have been through the trauma of being diagnosed with breast cancer, often at a young age, and now have an associated genetic mutation that they carry, in them, and frequently worry about what this will mean for them and their family. We feel, and I believe that they do as well, that we're able to offload some of the anxiety of having that identified problem or risk, rather, and helping them to know that it's being watched, it's being monitored, it's being checked with the best that modern medicine can offer. And the goal of doing this is to detect cancer at an early age or early stage when it can be removed before it can spread.
And Dr. Miller, I think people are familiar with screening for mammograms, prostate health, things like that. So I think remembering that screening is looking for a problem before it becomes obvious that it's a problem to anyone. So we're looking for those early signs that we can nip it in the bud, as the expression goes. And I also want to just acknowledge that there's been a lot of change over, years. You hear mammograms. Is it what's the age group? Colonoscopy just changed. So there may be changes in the future. So just if you're looking at the slide deck later, make sure that you take into consideration some of the guidelines may change. It's our job as clinicians to be up to date and be operating on the best science available. And that will change. And so we're excited as practitioners that we'll be able to offer screening, hopefully, to more people in the future as the evidence justifies why it's worth the stress of doing that.
Absolutely. Absolutely. And this is a challenging one to get a grip around, because it's not one that's offered for the general public. This is the third pancreas cancer, the third most common cancer killer, yet it's not one we screen for. We screen for the other two above it, but not for this cancer. And that is it's a very complex discussion as to why that's the case and why it isn't supported. But essentially, it's underlying that it's a very difficult disease to catch, and you have to choose the patients who are going to be able to benefit from it. And this is the best guidance we have now, and that's what we're able to offer here. How is pancreas cancer diagnosed? There's really two pathways that we see arrive in front of us. One is when there's symptoms, and those often involve abdominal pain, poor appetite, losing weight, turning yellow. Sorry about the jargon there, Anna. You always catch me with that.
You can read my mind.
I'm getting good. Been zapped too many times, I know. Or the incidental pathway. So there's the pathway that is symptoms that result in an imaging study. And there's a pathway that's when something's done for other reasons. I keep blaming these kidney stones, but we do see this. Lung cancer screening we've seen before, where patients get something done for screening for lung cancer because they have a smoking history, and then something is seen in the pancreas and we're able to catch that. It involves a CT scan or an MRI scan, and then the finding of a solid organ, a solid mass or tumor on the pancreas. So when that finding happens, we move quickly, and we have a team to help us get patients through this in the most humane and attentive way possible. Our nurses are specialized in counseling patients who have these findings and prepping them for this procedure, because although we talked about with the cysts, how we want to have a clinic consultation for counseling, in this scenario, in our climate, in our part of the state, we want to move very quickly and get patients to the procedure. And what this would involve is an endoscopic ultrasound exam, as we discussed before for the cyst. We again use the needle. In this case, we're taking tissue in a very diligent way and trying to have the support of a cytologist often during the procedure when we can, to help us make sure we're in the right place with our sampling and give us some information. And then
just let me pause you there. The cytologist is a medical doctor who can interpret look at the actual tissue and say, you got a good sample, Dr. Miller. We can make the diagnosis right now. Is that what we're talking about, Dr. Miller?
That specialist, absolutely.
Yeah.
And this is a difficult disease to diagnose. And even when we do have relatively findings that are supportive of this, in the case, there can be times where we have to go back for more tissue. And that happens at every center. This is a difficult entity to get into the needle and to get samples that are going to be useful and able to be diagnostic. And then we get that tissue, we get it to the microscope doctors, the pathologists, the diagnosis is made, and we'll try to move patients on efficiently to get them some of the additional tests that they need for assessing their candidacy for treatment, including additional CT scans, often of the chest, to follow after a diagnosis of pancreas cancer is made, because the abdominal imaging, the belly imaging is already done. Lab work is often done. And then we get these patients to a multidisciplinary team that consists of a cancer specialist, a medical oncologist, a chemotherapy doctor, a surgeon who specializes in removing tumors, often a radiation oncologist, or a doctor who specializes in using radiation to treat cancer. We remain a part of the team to help, because there's a number of things that we can do to help these patients in the months ahead with keeping the liver draining, because that tumor, as we showed, sits right below that pipe of the liver and often needs to be opened up with the tools that we can use. We work with radiologists to help when needed to get additional tissue from other parts of the body, or help make sure that the structures are draining right and appropriately. And we work with your radiologist and your primary care team. So there's a lot of people that come together in this group called a tumor board of experts to make decisions about what's the best plan for each patient. Right now, surgery is the only treatment that can bring cure to pancreas cancer. Candidacy depends on if there's spread to other organs and the patient's performance status, how strong they are to be able to undergo surgery. Modern treatments and chemotherapies are helping more patients to reach surgery because they're beating the disease back a bit so that the surgeons can then take the disease out. The term neoadjuvant is thrown around a lot, and that means therapy given before the main treatment or surgery. And that's a lot of times the mainstay for these diseases. And then many patients, unfortunately, will not be candidates for surgery, but may still have a very meaningful response to the therapies that can be offered, including chemotherapy, that's the liquid therapy injected into the vein, and then radiation therapy. And then our role, I'll just briefly say, can remain in the case to help to keep the critical structures and pipes open. We often can get involved later. This disease can cause pain and difficulty with upper abdominal pain and requirements of medicines to treat that can be difficult as well. So we can use our ultrasound probe to even treat the nerves that are irritated by the tumor. And then we can use some of our tools to help keep the GI tract open so patients can be eating and staying strong through their course of therapy. So in summary, a complex organ and a difficult part of the body that's very important for storing and releasing sugar. Cysts are very common. It's rare to see cysts, exceedingly rare to see cysts turn into cancer. This is not an emergency when you're found to have a pancreas cyst. We have smart people and great guidelines to help navigate those next steps for you. Cancer is a complex endpoint for the risks, including genetic and exposures. And we understand some of those things and risks that lead to increased risk of pancreas cancer, and some of them we don't understand that well. We're moving closer to diagnosing disease earlier and earlier, so we can have effect with curing the patient and getting the cancer out early. And patients can also do very well with prolonging life from modern chemotherapies. And our role in endoscopy remains to help patients live active, quality lives while they're undergoing therapy, and if they can undergo surgery, and keeping them active and engaged in their life. And I can pause here, Sue, if you want to pause for questions. I think Anna and I are happy to answer some. We also have some to add in. I know it's getting late in the evening and people probably have a dinner to get on and kids to put to bed as well.
Thank you. What a great talk. Really, thank you. And you're a great team together, too. I applaud you both.
We have chemistry.
You definitely do. And this is really awesome information. I thank you for that. I will email the attendees on the list the link to the recording so that they can review the content again. There is one question in the queue, and I'll paraphrase a little bit.
Sure.
But they did have an ultrasound for another problem, like you actually talked about in your talk, and they found mild dilation and in their main pancreatic duct, and they're just wondering if there's a concern about doing an MRI follow-up.
Oh, sure. Yeah, very common question. In general, the size of that duct should be about 3 millimeters on the head, 2 millimeters in the body, and 1 millimeter in the tail. And so if it's above 3, and they didn't get a great look at it, and ultrasound's a great tool, but it's hard for them to see the pancreas all that well. If it can, my opinion is if it can add some reassurance to the patient, an MRI scan to follow it up, it should be a good, easy next step without radiation exposure. And primary care should be able to help with that, I think, without much pushback from insurance. At least I hope not. That should be something they can get through.
Excellent. And there's more questions popping up. So the next one, will a lung cancer CAT scan show the pancreas?
It typically has some cuts on the scan, meaning some of the slices of the scan. It's the scan. It's like taking your body and going like this all the way down, boom, boom, boom. Some of it will capture the pancreas below the belly. It is not a great tool for looking, for dedicated ways at the gland. The timing of the contrast will be more relative to the chest. Sometimes they don't even need to use contrast on chest imaging. And we really, when we're looking at the pancreas, want to see contrasted studies. So it's good for picking up when there's problems that are there overtly. But if your question is pancreas, you want to use a pancreas imaging tool that more refined and focused on that gland. So abdominal. Yeah. And
let me add on to that, Dr. Miller. I think sometimes people wonder, oh, I've had this other test done. Am I off the hook? And I think what you're describing is that maybe, but we can't see the whole organ. So we can't tell you definitively that something isn't below the slices where we can see it, or because we don't use the special contrast, which is the special thing that makes it light up in a certain way so that we can identify things differently. Sort of like a highlighter, I guess you could think of. We use a special one when we do it that's different than what the lung team is looking at. So it's complicated is really the takeaway.
Yeah.
Well, thank goodness you know what you're doing. The next question is metformin therapeutic in the event of prediabetes and family history of PC? And I'm confused about the question.
No, I think I know where they're going. That's a great question.
Okay.
That's a great question. Yeah, really interesting. And it gets at some interesting points here. So is metformin helping to using for prediabetes, which is an indication I think Anna in primary care has more experience with than I do, but certainly a reasonable one. Is it help perhaps in patients who are higher risk for pancreas cancer from a family? And I would say that I think that we view diabetes more as a symptom of the problems in the pancreas and less so as a cause for pancreatic cancer. That said, when diabetes comes from oftentimes what we say metabolic syndrome, the vague term for body fat in the wrong areas, leading to problems with different organs, including the liver, the cardiovascular system, that is the root that I think is more the cause for both the diabetes and the pancreas cancer. So I don't know that metformin would be a meaningful piece to decrease the risk for pancreas cancer. But I think they both share the common root of body fat in the wrong places causing some trouble. And but the goal of trying to really work on whatever led to prediabetes and with activity, exercise, weight loss, healthy eating, those things are going to help decrease the risk of pancreas cancer, but not necessarily metformin.
Thank you. I know we're a little over time. Do you want to take one more question?
Sure. Yeah, no problem.
Okay.
I want to just put a plug in there real quick, though.
Sure.
Also, quitting smoking if you smoke. 1-800-QUIT-NOW, 1-800-QUIT-NOW. You can get free taxpayer Massachusetts supported support. So please do it. I love talking and helping people quit smoking, but that's one of the biggest risk factors for pancreatic cancer. And that's something that people can actually do.
Wow. That's great.
1-800-QUIT-NOW, 1-800-QUIT-NOW.
We got to get you to do a reel on that, Anna. I'll be in touch.
All right.
So the next question, does the MRI need to be with contrast? They have an allergic reaction, but they do have, infectious pancreatic thing.
Sure. In general, that disease sounds like it's probably inflammatory, so maybe less worrisome for something like a cyst that could be developing trouble down the road towards the worrisome cancer kind of things. But the contrast really aids a lot in the caliber of the study and to get a better visualization of these difficult structures. A reasonable alternative would be to do IV contrast with a CT scan. A triple phase CT scan is an excellent study. Again, some radiation exposure with that, but that would be able to image the pancreas well and provide some reassurance here.
Excellent. Okay, we'll make this the last question because it's, I think it's a good one to end with, but does a first degree relative and a smoking history qualify for screening?
First degree relative. It doesn't in the current paradigm. And this is a conversation we frequently have a challenge with when there's people who have risk, and we appreciate that, but it doesn't meet the current guidelines. And then we're struggling with how to navigate and advocate for a path with imaging. And I think that that warrants a good clinical assessment and an evaluation of the overall risk, symptoms. There may be a path forward here that could result in imaging or could involve perhaps just a vigilant clinical course of watching for symptoms. And but it's a difficult one. I think that one needs some clinical assessment, some one-on-one assessment of risks and pulling together.
And Sue, I know we're at time, but there's one thing that comes up in clinic with me a lot that I'd love to just make sure we expose.
Absolutely.
Which is many people take advantage of our neighbors to the east, especially. There's great clinics in Boston. And this is something that people often wonder about, how that connects to the care they receive here locally at Baystate. Because we are really providing a service that is very, not many places do. So we're really proud of the work we do. And then we offer this locally. But sometimes people choose to get a second opinion, and they're worried that what does that mean for their relationship here with Baystate Health? So I wanted to throw that to you, Dr. Miller. Just to reassure our patients that we're all part of a big care team.
Oh, absolutely. We work very closely with our colleagues at Brigham and Mass General and Beth Israel sometimes, as well as Dana-Farber frequently. Our oncology program readily corresponds and will work on a treatment plan that will integrate the input from Dana-Farber and apply those therapies more comfortably for the patients here in our community. I think what we take a lot of pride in is that the things that you get done here are of the caliber that you get done in Boston.
Yes.
That's our, of paramount importance to us. That said, because we care that much about that quality, when there's things that we don't know that we can do with that excellence, we ourselves, or with your help or your primary care team help, will help you get to Boston, to our colleagues there for those procedures that are needed, and then happily help with things on the back end over here when you come back. And so that's never an issue, and there's never a matter of pride. And honestly, we're grateful for the expertise at times too. It's nice to hear what these guys think. They're the ones who give the courses and teach nationally. And sometimes the things that stump us are the things that stump them.
Right, exactly. Well, it's great that, you're all working collaboratively, and really that we have your expertise, advanced endoscopy at Baystate. And I just want to mention your contact number is 413-794-7364. And it'll be part of the survey if anybody needs any follow-up appointments or appointments with you. We can help them with that.
Yeah.
But thank you both.
Absolutely.
Oh, go ahead.
Oh, no, and we're just very grateful that Baystate has supported us in getting some colleagues. So I've been grateful for Dr. Desolitz, Dave Desolitz, who's been carrying the load of advanced endoscopy in Western Mass for 20 years and building this program and taking care of so many patients in our community here. And I hope he continues to stay for a while and help me, even though I'm not sure he will too much longer. But we also are grateful for Dr. Kai Sakaria, who joined our group a year ago, and just recently this summer, Dr. Na Dong, who are fantastically skilled clinicians and endoscopists, and so we're really in a good position to keep this service and to grow it further here.
And we'd be remiss if we didn't thank our chief, Dr. Gowie, whose visionary leadership is integral to our success at growing our program. So we appreciate the team that you see and the team that you don't see behind the scenes.
That's awesome. Well, I applaud all of you. Thank you very much for your time and expertise tonight.
Thank you for joining. This is a love to have this audience. Thank you.
Thank you.
Be well.